afternoon, and good afternoon to what I hope you I would very much like to call up our first speaker, Dr. Pranay, who is the co-director of the Ecmo program at the Vinayak Hospital in Mumbai.
Thank you for inviting me for this conference. I'll speak on the clinical aspect of hypoxia during VV Ecmo, and then subsequent lectures will be taking care of the detailed aspect of it. So I'll just give and how will you approach to hypoxia. So whenever you are approaching to any troubleshooting, you have to first recognize the troubleshooting, and then you have to decide whether you can accept it or you have to intervene in that. You should think about what will be the immediate management, uh, what will be the cause for this, why it has occurred, and then you have to go for a root cause and find out the root cause so that it doesn't repeat and manage the root cause. So assessing hypoxia is not just a number. You don't have to just look at a number, whether it's a PO2 of 45 or PO2 of 50 or SPO2 of around 80 or 75 or 70. That does not only define the hypoxia. Hypoxia is basically a clinical syndrome where you have to see the rest of the part, like assessing the neurological status, monitoring the patient's vitals, tachycardia, whether the patient is hypotension or hypertensive, or patient's lactate levels, urine output, and overall clinical scenario. If that fits in, then only you can define person is an hypoxia, not just by looking at the numbers. So what are the factors that affect the saturation of VV Ecmo? It can be Ecmo circulation related, so it can be because of flow. If the flow is not adequate enough, you get hypoxia. It can be because of Ecmo effort, which is less, or it can be because of the oximeter, which is failing. That all can Ecmo related causes can lead to hypoxia. Or the most important factor that remains is the recirculation. So if your both the canals are close to each other, if flow is too high, it can give us to recirculation. Second factor that can give us to hypoxia or decrease in saturation is native circulation, because it is going to be in series. So even the native circulation will also play some role. So ventilator settings, your FiO2 and PEEP, and the lung status of the patient, that also contributes to some extent to hypoxia. The third most important factor is the ratio of ECMO flow and cardiac output. So these are basically the dilution effect that takes place. So how much fraction of your total cardiac output you are oxygenating, it depends upon that. So if the cardiac output increases and your ECMO flow remains the same, that will itself can lead to hypoxia. So what is the management strategy for this? It's correction of the causative factors, whichever is there, decreasing the demand by manipulating the cardiac output, and increasing the supply either by increasing the ECMO flow or by increasing the hematocrit. So correction of the causative factors, most of the time you have to just look for the technical and mechanical issues. You have to correct technical and mechanical issues. Look at the oximeter. If there is oximeter failure, you might have to change the oximeter. Look at the recirculation, and you have to correct the recirculation. There will be a separate talk on that, so I'm not going to talk on that. Improving the parenchymal function, that is most important, and correcting the demand and supply ratio. So this is the way you should approach. Whenever you see a hypoxia, look at the tube color. If both the tube colors are same, that means there is a gas flow. Either there is a gas flow failure or recirculation. See the color of the tube, dark or bright. If that is fine, then look at the technical issues, whether your pulse oximeter is connected properly. Look at the flow, if the flow is adequate. Okay. Look at the patient is restless, patient is febrile, patient is sepsis. Again, that suggests you have high demand of the patient. Look at the delta pressures, that tells you about the oximeter failure. Look at the X-ray and 2D echo, that tells you about the parenchymal worsening. Okay. And the management, as I said, depends upon the correction of positive factors, increasing the supply and decreasing the demand. This is the most important part, which usually once we put the patient on ECMO, we don't bother too much about that, and that is improving the parenchymal lung function. Earlier the lung improves, early better is the outcome, because you can come off ECMO at fast. So it depends. Your probably if the lungs are not flooded totally, you might have to think of doing bronchoscopy and tracheal lavage. If there's a pneumothorax, you have to put an intercostal drain. If the patient is volume overload, give diuresis. Try all the efforts to make lungs recruit and prone position. You might get the lungs completely obstructed. You might have to remove the clots from the lungs. Okay. One of the most important factors where we can improve the lung function or you can recruit the lung is by giving a prone position. So prone position of the during the ECMO is not a contraindication. Either you should rather you should start doing that from day one only. That helps to a great extent. There will be a separate talk about that. Give active physiotherapy, postural drainage, make them to sit, make them mobilize. Okay. That all things is going to help to improve the lung functions. Another factor is manipulation of cardiac output. Treat the cause of increased cardiac output, so treat fever, if patient is awake and just give them sedation, treat the sepsis. Decrease cardiac output with the help of beta blockers or in the sense of if you require, you can think about hypothermia and increase the blood flow. That is the way you can manipulate the cardiac output. So increasing cardiac output definitely will causes more of a dilutional effect and that leads to drop in the saturation. So what you need to do is you have to try to get the cardiac output down by treating underlying cause or give beta blockers. Okay, and there are various studies which show that by getting the cardiac output down, your oxygen saturation, the fraction of the blood gets oxygenated changes from 50% to 75%, and that itself increases the saturation. Similarly, if you can get the temperature down from 37 degree to 34 degree, the saturation will improve from 82 to 94%. So that is one of the way by getting decreasing the metabolic activity, you can improve the saturation. The reason why I don't pull all the patient is that it will increase the risk of infection, immunosuppression, arrhythmias, coagulopathies, and drug metabolism. So that's the reason we don't try to pull all the patients. Next is the maximizing the blood flow. So you have to maximize the blood flow, but then it carries a risk of hemolysis. If you go more on the flow, it carries a risk of hemolysis. You have to balance. You have to go for a adequacy of the support and the safety of support. So you have to balance both how much you can give flow, how much you can go up on the flow. If the flow is inadequate, you can put an additional cannula to get the better flow. And if the flow is more, like in case of sepsis, where you require the flow might be more than 7 liters, 8 liters. Okay, in that case, you might have to think of putting an additional oxygenator or dual oxygenator. If increasing the flow also does not help, then you have to think about increasing the hematocrit. So give blood and keep the hematocrit of more than 40 if the saturation is less than 80, and that probably helps into improving the oxygen delivery. The last resource is going to be conversion of VVA ECMO to VVA ECMO, where when you require that, suppose you feel that you require circulatory support or there is a right heart dilatation or right heart failure, or there is a refractory hypoxia which requires correction, in that case you have to think about converting to VV to VVA ECMO. So how will you approach is look at the saturation. So use hypoxia, decide whether that requires any treatment. So look at the lactate levels. If the lactates are fine, you definitely need to do. If the lactates are high, you have to do. You need something else to correct this hypoxia. Look at the vitals, urine output, neurological stability. Okay. Look at the tube colors. The immediate management is going to be look at the technical issues, the tube color, the FR2, the flow of the ECMO circuits. If that is all, everything is okay, you increase the blood flow temporarily. If you find something going wrong with the ventilator, with the ECMO, then only you go up on the ventilator settings. Otherwise, don't go up on the ventilator setting. If patient is restless or sedate, then sedate the patients. Okay. So you usually divide the hypoxia in sudden versus gradual. If it is sudden, most commonly it is more of a mechanical issues like in case of either sweet gas failure or recirculation. There can be a flow issues or increased metabolic activity. All that can cause to increase in the hypoxia. Okay, and management is by going by treating the cause. To improve the oxygenation, improve the flow. The lung-related causes can be an obstruction of mucous flow, then probably might have to think about doing bronchoscopy. If there's a pneumothorax, might have to put ICD. But you have to be careful while putting the ICD because patient is already going to be on heparin. So you have to decide whether the ICD is absolutely needed or not. If I told you delta pressures, then change the oxygen. And if nothing is going to help, target the hemoglobin on higher side so that you can improve the oxygen delivery. So most important is the take-home message is you correct the course. You increase the supply. By increasing supply, you have to increase the blood flow. Blood flow up to 5 to 6 liters are usually fine, but then look at the circuit pressures. If the circuit pressures are high, probably that will lead to hemolysis. So you have to always keep in mind you have to think about putting a triple cannulation to put an additional cannula for drainage, dual oxygenator, or increase hematocrit. Decrease demand by sedating the patient, treat fever and sepsis, use of beta blockers and hypothermia. Most important while you are troubleshooting the Ecmo, okay, you have to balance the adequacy as well as safety. See, many a times you find that there is a you can go up on the floor, you have still a margin to go up on the floor, you have margin to give blood. So you have to find out what is going to be more adequate and what is going to be more safer. You have multiple options to improve the oxygenation in terms of, as I said, you have to go, you can give the blood, but then you have to balance what is going to be more beneficial and what is going to be less risky. So you have to attempt that. The most important than that is you have to start making an effort from day one about the lung functions to improvise. Because that is the word usually we neglect it. So we always keep on talking about give rest to the lungs, give rest to the lungs. Yes, it is important to give rest to the lungs, but don't make it lazy because then it will take further more time to get up. And then more the time they spend on ECMO, more is going to be the risk. Okay. Thank you.
It was a wonderful talk, Dr. Again. You made these subjects look so simple. It's just 1, 2, 3, and you go down the algorithm and manage. It's not that easy. You know it, and you know it. Thank you, sir.
Thanks.
We'll take the questions at the end. Now I have to invite Ram. Dr. Pragyan has set the ball in motion. You have to now, kind of tell us how much of the PO2 you will accept, how low or what is the level of hypoxia which you will accept.
Thanks, Dr. Bala. Good afternoon, everyone. I know you have all had a heavy lunch. Your eyelids should be drooping by now. So I stand here to question conventional wisdom at the outset. Let me take you through what I have to say when it comes to how low is low PO2 when you run when you're running a patient on VV ECMO. Right. I know you all would have heard about the Murphy's Law. So if something can go wrong, it will definitely go wrong. That's what Murphy's Law states. Now, the reason why I'm saying that is when you have a patient on veno-venous ECMO, the very first decision to go on veno-venous ECMO was to offset hypoxemia. Now, you have a patient on veno-venous ECMO who's still continuing to desaturate. Now, that is a matter to worry. How do you deal with it? Clearly, the purpose for which the VV ECMO was started, it's clearly not working well, and you need to think about why it is not working well. Now, let's go further as to questioning why it's not working well. Now, before we start questioning why it's not working well, let me get the basics right so that we understand this concept better. First and foremost, let's understand what is hypoxemia and what is hypoxia. As long as you get this concept right, understanding further concepts would be much more easier. So hypoxemia, a patient is said to be hypoxemic when his blood levels of oxygen is low. So your pulse oximetry shows that he's got low saturations. But the same patient is hypoxic when there is low oxygen in the tissues. So once you get this concept right, we move further. We need to now know what is refractory hypoxemia. Now, if you go through literature per se, especially the arts literature, you'll find that there is no proper definition of refractory hypoxemia. This was a paper that I published in the Red Journal about 7 years back. I don't think things have changed in the last 8 years in any big way. Hypoxemia being deemed refractory, there are multiple definitions to it. You either go by your PF ratios, you go by your Berlin definition, or any other way to define hypoxemia, like how the Cronin investigators did in their trial when they defined refractory hypoxemia. So clearly, there is no consensus as to what refractoriness is when it comes to hypoxemia in ARDS. Now I'm going to add in another layer of complexity. What is hypoxemia on Ecmo now? Clearly, venovenous Ecmo is supposed to offset your hypoxemia. When it doesn't, and your saturations or your PO2s of the patient start going down, you have hypoxemia. But when you clearly define it, the only thing we have right now, it's probably a consensus statement, and that too, it's part of ELSO guidelines too, is that you maintain SATs of anywhere above 80 to 85 at rest when setting. So if you think about it logically, any saturations less than this can be termed as refractory hypoxemia on Ecmo. And of course, as with the ELSO definitions, there are other institutional protocols that define refractory hypoxemia on Ecmo differently too. So the point I'm trying to make here is there is some blurriness about what refractoriness is and what low PO2s you can accept. Now comes a major thing. If we are talking about hypoxemia on Ecmo, do we have to really worry about it? Or how frequently do you get to see it? Well, it was observed that about 9% of the patients in the Caesar trial had refractory hypoxemia. Clearly, the definition was different, and I'm not going into the depth there. About 6% of those patients who were included in the ANS Ecmo study for the H1N1 ARTS, they had refractory or intractable hypoxemia on Ecmo. And one of the French studies quoted almost 1/4 of their patients getting intractable hypoxemia on Ecmo. Now, why are we worried about hypoxemia? Is this something that you need to worry and you need to correct at all? Now, that's where I have two papers to show you to compare and contrast. The first paper is a study that looked at ARDS cognitive outcomes, the long-term outcomes after ARDS per se, when patients were mechanically ventilated. Clearly, long-term neuropsychological function was impaired in these patients who were mechanically ventilated for ARDS when they had refractory hypoxemia. Do we have any such data on patients who have been hypoxemic on Ecmo? So when I searched the literature, one interesting paper popped up. This is from the Karolinska. And what they showed was, despite hypoxemia being despite your patient being refractorily hypoxemic on VV Ecmo, it doesn't make a big difference to the neurological outcomes in the long term. Clearly, there is a difference between what we get to see in ARTS patients who are mechanically ventilated and VV Ecmo patients who get hypoxemic. Now, why is this difference? You need to think about why this is happening, and there are different ways of thinking about it. To me, when your patient on VV Ecmo gets hypoxemic, the way I go about it is there should be some reversible factor somewhere which should be easily correctable, or there should be some irreversible factors to which I need to pay attention to. So if the patient has reversible factors, I clearly correct them. It's easy for me but I still look for them. And it makes my life easier if I get to see the oxygen saturations or PO2s or whatever it is improving. Now, what happens if the patient still remains hypoxemic after I correct all those reversible factors? Okay, the plot gets thicker now. We now have to figure out wherein lies the problem. Is it a problem with the patient? Is it a problem with the circuit? Is it the way we are interpreting the ABG in terms of PO2? Is it the way you are interpreting this whole scenario in terms of patient's clinical condition? Or is it the pulse oximeter that is clearly distracting us? To me, the big elephant is still in the room. It's none of these things that actually depict actual hypoxia or the refractory hypoxemia. The problem really lies in all your brains. It's the way you perceive hypoxemia in these patients that the problem lies. Now, what exactly do I mean? Oxygenation on VV Ecmo is a different ballgame. Conventional perception of oxygenation in terms of saturation and PO2, that's how our brain thinks. But when your patient is on VV Ecmo, this doesn't work. Because on VV Ecmo, you are incapable of estimating the amount of oxygen present in a mixture of two separate blood flows. So you have the patient's native blood flow and you have an ECMO blood flow that has two different oxygen contents. And to interpret this in terms of PO2 and SPO2 is not correct. Then how do you interpret hypoxemia, or when do you say these patients are hypoxemic? Are there any yardsticks to measure this? That's where you need to be clear with your concepts. So for a patient who is on VV ECMO, the oxygen content in your arterial blood, the oxygen delivery to the tissues, the oxygen uptake to the tissues, these should be used as yardsticks of oxygenation. And that's more complex because these have complex equations which you need to think of. Clearly, when you have complex equations in front of you, your brain tries to ignore it. The easiest thing that you can see on the monitor is your SATs or your PO2 on your ABG, and hence we go by it. But this is conventional wisdom. You just have to be getting over that when you treat patients on VV ECMO. So to go a step further, to explain this more, you need to understand that when oxygenation is inadequate for your patient on VV ECMO, your delivery of oxygen clearly doesn't satisfy your tissue demand. And this usually happens when your delivery to oxygen DO2 to VO2 ratio is less than 2:1, right? Now, the biggest problem in clinical practice is you cannot measure VO2 directly, while DO2 can still be measured using the various parameters you have by the bedside. As I said, these are complex mathematical equations. Your brain doesn't want to do it when you see your patient saturation of 70. But this is what reality is. So when you cannot measure VO2 directly by the bedside, you either do a calculation that is based on, say, normal acceptance, or you do look at surrogate markers, right? So again, I'm making this complex. I'm trying to make this complex physiology a bit more simpler. The point I'm trying to make here is DO2 by VO2 ratio is a good yardstick of poor oxygenation for a patient on VV ECMO, but there are certain limitations to measuring it. Now, how does it work? So, in the normal body, your DO2 to VO2, your delivery of oxygen to the tissues is about 5 times the tissue demand, which essentially means there's a big buffer out there which can help even if the tissue demand goes up. Now, the tissue demand can go up with exercise, catecholamine, or if the patient is in a septic state. Now, what happens in those conditions? Your body readjusts to such a situation by increasing your cardiac output. So, essentially, your delivery of oxygen is still maintained. Now, you also need to understand that in a pathological state or in a disease state, the DO2 and VO2 do not function separately. There can be situations where one can rise, the other can go down, the other can rise. So there can be various permutation combinations that can happen with the DO2 and the VO2 values. So it's not something which is going to be easily predictable. The other thing that happens when the rate of rise of your tissue oxygen demand is higher related to your delivery of oxygen is your tissue starts extracting more oxygen. So essentially what happens is, as I said, there is a buffer there. Blood that reaches the tissues start taking in more oxygen to meet that demand. And the blood that leaves the tissues, that comes back to the right atrium, has a very low PO2. And that explains why your patient eventually desaturates when the circulation happens. At a point where DO2 by VO2 ratio is less than 2, anaerobic metabolism happens. So coming back to the question, what happens? Let us say in this scenario, you stick to your PO2 and SPO2 values and do what you normally do. You have to understand that even with a PO2 of 50 or 60, your DO2-VO2 ratio would still be more than 2:1. There is no need to do anything to this patient's any settings. At a point where your saturation hits 75 or your PO2 is around 35, the DO2-VO2 ratio is around 2:1. You have reached the tipping point. And that's probably the time to react. So very often by the bedside, our reaction is increase the FiO2 or change the ventilator settings. Mind you, both of this are going to do more harm to the patient than benefit, and it is going to cut down your DO2-VO2 ratio faster than before. So please don't do that. What else can you do? Think about what else can be changed. Can you change the hemoglobin for this patient's blood? Yes, you can transfuse blood. So that your DO2-VO2 ratio is somewhat, it comes back to your more than 2:1 ratio. The other thing is, see if you can increase the cardiac output. As Pranay rightly put it, additional cannulas might be needed. What's the third thing you can do? Essentially, see if you can cut down on your tissue demand for oxygen. And that's exactly what you do by cooling. While you do that, additional measures that you need to do is to make sure that the tissue doesn't go into anaerobic metabolism. So you need to have a closer monitoring of your lactate and base deficit at that point. So finally, the last slide, how low a PO2 would you accept? To me, the answer to this question, PO2 is not the right yardstick to measure tissue oxygenation on Ecmo. You don't have to worry about it till you start thinking about DO2-VO2 ratio. This is the right yardstick to look for oxygenation on VD Ecmo. The moment it hits less than 2, your tissue would turn to anaerobic metabolism, and that's what is easily monitorable by the bedside in terms of lactate or base deficit, and hence, going by that, you can accept as much low sats as possible as long as your DO2-VO2 ratio is about 2:1 and your tissue is not in anaerobic metabolism. So to conclude, for every Murphy's law, there should be an anti-Murphy's law. If things can go wrong, the point here is don't panic, take control, and you can set it right. Thank you.
Dr. Jayanti Kishore. She is a specialist in pediatrics from Hyderabad, India. She will be talking about my patient hypoxic VV ECMO with problem with recirculation.
Ram had covered most of the aspects. Nothing much for me to do except the recirculation part. I'll just emphasize a little bit on the hypoxia and then go straight to the recirculation. So as Dr. Pranay already mentioned, the factors influencing oxygenation in VV ECMO are volume status, including cardiac output, the ECMO flow, which again depends on partly on the cannula and preload, ECMO flow to cardiac output ratio, oxygenator function, oxygen delivery, consumption, pulmonary shunt, and recirculation. This is a formula which actually combines most of these, which actually is the residual pulmonary function plus the effective ECMO flow, which eliminates the recirculation part, and the ECMO flow, which is actually in the patient, the flow which is in the patient, which doesn't go into the ECMO. This is another chart which I found, which already they have spoken about it in detail. So optimize the ECMO flows, then go for and reassess the recirculation part. Coming to this part, I can stress on this. If the drainage cannula saturation is more than 70%, or the difference between the drainage cannula saturation and the return cannula saturation is less than 20%, we can suspect recirculation, and there are methods to tackle that. So if it is not there, then we, as Dr. Pranay mentioned, we need to optimize the cardiac output, reduce it, look at the oxygenator function, and optimize the lung, and do bronch ventilation, add nitric oxide, etc., etc. Then I don't need to talk about this. So this is an interesting slide. I found that if the cardiac output is around 5 liters, 3.5 liters goes into the ECMO, 1.5 is out of ECMO in the patient. this patient won't be hypoxic. Whereas this patient, where the cardiac output is 10 liters, only 3.5 liters goes into the ECMO and 6.5 liters is still out of ECMO. This patient becomes hypoxic because most of the cardiac output is not being circulated into the ECMO. So this actually shows that we need to maintain a ECMO flow to cardiac output ratio of at least 60%. If you see here, if 60% or above is maintained, the ratio, the saturations are better. And Dr. Nicholas and Dr. Ram mentioned about this, and that we actually need to look at the membrane lung PF ratios and the shunt fraction, and which are inversely related to each other. PF ratio is a user-friendly parameter, but it actually takes into account the high metabolic demand, so it's not always reliable if the oxygenated function is not good. So coming to recirculation part. Recirculation is how to calculate this. It's pre-oxygenated saturation minus SVO2 by post-oxygenated saturation minus SVO2 into 100. If the pre-oxygenated saturation is the same as the SVO2, there is 0% recirculation. And if it is the same as the post-oxygenated saturation, there is 100% recirculation. If there is a pre-oxygenated saturation of less than 75%, clinically significant recirculation is unlikely. And the relative volume in the SVC IVC also is important. If a reduction in the IVC flow related to the SVC is there, there is a higher recirculation in femoral jugular configuration. If you see this slide, the cannula are overlapping. You see almost for the same ECMO flows, the saturations of the pre and post saturation, the SVO2 and the saturations are almost the same. Whereas if you separate the cannula here, the distance is separated. You can see that the patient saturation improves. So this is how the recirculation is usually addressed, by keeping at least some distance. How much distance? At least 15 centimeters, 10 to 15 centimeters between the two cannulae. There are three different configurations here. So this configuration is drainage from the atrium and returning back to the femoral. So this is not advisable in adults because here the recirculation is the highest in this configuration. And the second configuration is drainage from the femoral and returning to the atrium, right atrium. And here the recirculation is the lowest. Whereas if you actually drain both from SVC and IVC and return back to the IVC, it's slightly higher than the previous modality. In these configurations, where there is these are the ideal cannulae positions in femoral drainage to atrial return, and the femoral. Because in femoral, if you see, the drainage should be lower and the return should be close to the heart, that almost close to the atrium here. If you do the reverse, the recirculation will increase because the drainage will be at higher and return will most of the return blood will be sucked into the drainage cannula. So for these patients on VV ECMO, the best thing is to increase the distance between the drainage ports, and at least by target a distance of approximately 15 centimeters. If you are still not able to manage, add a drainage cannula to achieve a similar pump flow for a lower pump speed. Sorry. And switch over to another double lumen cannula if nothing works out. So if you see these graphs, with increase in ECMO flow, the recirculation rate increases. This is a complex interplay where if there is a cardiac output of 5 liters, and you can see here that the total DO2 is increasing with increasing the ECMO flow fraction, and the circuit DO2 is also increasing. At the same time, recirculation also is increasing. However, if the flow fraction goes above 1, and that means you are increasing the ECMO flow and reducing the cardiac output, then the recirculation jumps up. It's significantly higher, and the DO2 comes down both in the circuit, and the total DO2 comes down as well. These are computational fluid dynamics studied by Louis Parker et al. And they actually showed different methods how they can actually increase the recirculation in different scenarios. If you see here, as you occlude the side holes of the femoral cannula, or any cannula, in fact, as you occlude the side, here we've shown the femoratrial configuration. As you occlude the side holes, the recirculation actually gradually increases. As you occlude by 25%, 50%, 75%, it's just going up and up. So, if you see in the atriofemoral configuration, up to 2 liters, there's not much of recirculation, but as you increase from 2 to 6 liters, there is a recirculation of around 39%. Whereas in femoroatrial configuration, it is only 26% as you go up to 6 liters. So, although there is no clear-cut definition of recirculation fraction, we accept more than 20 to 30% as significant recirculation. So in these both modes, if you see the in femoroatrial drainage, 5 liters is the threshold for significant recirculation. So in the same study, they have shown that as the recirculation decreases, effective Ecmo flow increases. And if you see the atriofemoral drainage, it doesn't matter where the cannula position is, whether it is distal or midway or proximal, doesn't matter. It didn't make a much difference in this configuration. So in this, actually, the repositioning the drainage cannula had no significant impact on the recirculation fraction. Here, Stephen Conrad and others have shown that if as the atrial volume increases, there is a reduction of the recirculation fraction, and as the heart rate increases, the recirculation fraction increases because there is less time for the blood to mix in the right atrium. And again, return cannula, as the SVC cannula orientation changes, the recirculation fraction increases. If it's at 30 degrees orientation, then the recirculation is less. Whereas if it's straight at 0 degrees, the recirculation is high. So the higher the cardiac output, the higher will be the drainage, ventricular drainage of the cannula, and smaller the recirculation, and vice versa. And there are a few neonatal studies also where the recirculation was measured by using ultrasonic sensors. Actually, what they've done is they've connected ultrasonic sensors on the arterial side as well as the venous side on the circuit. So they have infused a 5 ml of isotonic saline, and they've measured the change in the velocity, and they've actually recorded the dilution curves. So if they've given a fluid of 5 ml isotonic saline on the arterial side, they've also measured how much is coming back to the venous side, and the velocity change that recorded another dilution curve. If nothing came back, the curve did not record, and if everything came back, it was the same curve. So based on the ratio between the arterial and the venous curves, they have come to a conclusion how much the circulation was going on. So if what they have found is with lot of, because it's a neonate, with patient repositioning also there was a lot of recirculation going on. So there was a lot of the variation between 50 to 57%, which was very dynamic. So I think that's all about recirculation. So oxygenation on Ecmo depends on a complex interplay of various parameters. A complete understanding of the determinants of oxygenation is important. A native lung and membrane interaction plays a lot of role here, and we have to optimize the cardiac output and Ecmo flow to cardiac output ratio. DO2, VO2, everything is crucial. Recirculation, the factors causing recirculation should be identified if nothing else is causing hypoxia. Addition of cannula may be required, and sometimes changing ECMO configuration helps in certain patients. And definitely, as already spoken, lower saturations are acceptable if there is no tissue hypoxia. So there is a lot of difference between hypoxia and hypoxia. Thank you so much.
Speaker is Dr. Sunil Karan. He is Chairman and Head of the Critical Care Department, Manipal Hospital, Bangalore. He will be talking on the proning on ECMO, rationale and when. Welcome, Doctor.
So I will, in the next 10 minutes between now and tea break hopefully, I'll try to look at what is, when do we do proning on a patient who is an ECMO. So the evolution of ARDS, as you know, over the last 4 to 5 decades has gone on from change in nomenclature, better understanding of pathophysiology, what we were doing wrong in mechanical ventilation, then of course proning and Ecmo. And now we are talking about combining Ecmo with proning. Now this is not something which is sort of seen in the last 1 or 2 years. There has been reasonable amount of sort of not strong but good number of data or number of case reports and cohort studies which have actually been looking at proning as a potential possibility in those patients who are on ECMO. So the basic fundamental physiology on why we prone people will not change. I think with or without ECMO, the entire argument and the entire reason for doing that is to improve the whole is to improve the lung mechanism. So of course that starts from better postural drainage, improvement in the chest compliance, taking away the weight of the mediastinum so that allows better ventilator perfusion mismatch, reduces the ventilator perfusion mismatch, and of course better redistribution. So these are the fundamental basic pathophysiological principles on how proning or why proning was developed, and we know that it does change mortality in 2015-16 when the two big RCTs did show that it makes a big difference in changing mortality. So let's start with the important thing, which is gas exchange. Quite a few studies have shown that, including lots of case series and 2 or 3 meta-analyses have shown that there is no doubt that the PO to FiO2 ratio or the oxygenation is better with proning, which we know from data that we have used for ARDS in those who are mechanically ventilated. If you look at this meta-analysis by Gianni et al., where they have looked at different subsets of post-hoc analysis, wherein predefined subsets were looked at, you find that in most circumstances or in most clinical scenarios, you find that it is that there is the PO to FiO2 ratio, proning actually favors improvement in the PO to FiO2 ratio. Now, whether this translates into better outcomes is something which we are still not clear about. Though, as I will show you, there seems to be trends of that happening, and also to know whether a patient who is already on ECMO, predicting oxygen response or predicting improvement in oxygen is essential to determine whether a given patient will benefit out of proning. Because we need to understand that proning a patient on ECMO is not as simple as proning somebody who is on mechanical ventilation. So that is something we have to see if we can ascertain before actually taking the entire trouble of proning a patient who is on VV ECMO. Proning is known to cause a whole lot of improvement, as I said, and this improvement not only goes on to the different pathophysiological changes, which I have already mentioned, but also seems to make changes on the pulmonary vasculature or hemodynamics, as well. As you can see in this box diagram, where you see that generally there seems to be an improvement in the RV function, there seems to be an improvement in the lesser degree of pulmonary vasoconstriction, all that consequent to perhaps better oxygenation that we see in the better systemic oxygenation that we see. Now, though we have not been able to establish a direct correlation between improvement in oxygenation and mortality with improvement in mortality with proning, there is some data to support its use. In fact, some of these cohort studies or observational data also have shown that in those patients who did actually survive, there seemed to be longer duration of mechanical ventilation, longer days on ECMO, etc. So the other important factor of consideration is the fact that improvement in PCO2. Now, this study by Franchenius et al. Showed that there was a substantial improvement in the PCO2 from a mean of around 39 to a mean of about 31 in all those survivors. Now, whether this implied that proning helped PCO2 to get better, or that the lung was recruitable and the lung just got better, is a thing that we need to see. But certainly, improvement in the PCO2 with proning in these patients on ECMO does seem to show a better outcome. So overall, the exact effect of proning on gas exchange in patients with ARDS on VV ECMO is still a bit uncertain. Definite indication to show that it improves oxygen in the form of better PO to FiO2 ratios, and also determining the improvement in PCO2 or documenting the improvement in PCO2 is an important parameter to suggest the efficacy of proning, and also improves or predicts a good outcome when PCO2 does improve. The next important thing is on the respiratory mechanics. Now, whether there is data to compliance improves with proning, the outcomes seem to be better, but not necessarily as we see in some other studies as well. As you can see in this study, the overall improvement in the static compliance by about 3 liters, 3 ml per centimeter does show that these are patients who will benefit by proning. Of course, assessment of respiratory mechanics is often difficult in the clinical setting, and there have been studies using different modalities such as electrical impedance and indirectly using ultrasound or even for that matter CT scan. So assessment of the compliance or assessment of the recruitability of the lung, which will be an indirect marker of the compliance, is also an important indicator to suggest that proning will help in some of these patients. The problems with the compliance itself, as I said, it's very hard to estimate the lung compliance in a patient who is very, very ill. And it is not a sort of a uniform measurement of compliance, because as we know, the disease itself is heterogeneous. Even when we talk about extrapulmonary ARDS, though it's a fairly symmetrical involvement, there are areas in the lung which show a lot of heterogeneity. So the overall estimate of the compliance itself and its indication in clinical practice to suggest whether it does make a difference in terms of better outcomes or in prognostication is something which is still a bit of a question mark. So hence, as we know, individualization of PEEP is extremely important, and we have moved from the days when we have a sort of a make to fit all order to what we call individualizing PEEP. I won't go into the details of that, but the same methods that we use to individualize PEEP or ascertain what is called as an optimal PEEP for a given patient can be used in those patients on ECMO as well. Of course, we do have the luxury of the ECMO here, so it's quite much more easier to sort of ascertain the optimal PEEP in these circumstances. Different methods that are used are, of course, electrical impedance, lung ultrasound, which is probably by using the various lung scoring systems or the different quadrant lung scoring systems and looking at the summated lung score and see the response to the recruitment measures or to proning to indicate whether the given patient will benefit out of proning, and also to estimate the optimal peak for the given patient. There is hemodynamics itself was considered as a contraindication, but as we know, in the last 1 decade, this is not an absolute contraindication. In fact, if you look at the ProSeva data itself, we find that about 70% of patients were having hemodynamic instability and were supported with vasopressors. Hence, the hemodynamic instability is not a contraindication in a patient, even on VV ECMO to prone. But however, we have to ensure that there is a certain degree of stability of the hemodynamics on the given support before it can be done. There is no significant effect, that is documented effect of VV ECMO on hemodynamics itself, other than the time, as you know, when we initiate, there could be a certain amount of hemodynamic instability which can be compensated with adequate fluid management. So management of the hemodynamic instability would be one of the prime necessities to sort of put the patient prone, and the different indices that we use for conventional ICU patient can be used for measurement of the hemodynamic response or the volume responsive nature of the hemodynamic state instability. Now, the fundamental question in everything that we talk about is, are we going to change outcomes? As you know, largely in many situations in ICU today, we have not shown to change outcomes in many of our interventions. But what we also want to look at in the current scenario, in today's day and age, is to also look at improvement in morbidity, improvement in the secondary outcomes. There is not enough data to support the fact that proning in ECMO changes mortality. There is a trend towards a better outcome in this paper by Dr. Poon and Dr. Ramanathan, who is coincidentally here with us. So this meta-analysis has shown a trend towards a better outcome in patients who are prone with ECMO, which was also kind of replicated in this second meta-analysis, though the method of this meta-analysis was based on pooled individual data analysis, which was a little different from the previous one. But the important thing here again is that there was no statistically significant trend towards the outcome being better. On the other hand, this study or this meta-analysis which came out last year did show that there seemed to be a favorable outcome in terms of patients who are prone, and this extended from the 28, 60 to 90-day mortality. But this is all meta-analysis from various heterogeneous studies, and this particular meta-analysis also bifurcated the etiologies into COVID and non-COVID, and did find that this outcome was actually favorable in both subsets of patients. So whatever the etiology, there seem to be outcome benefit in terms of better 28, 60 and 90-day mortality in this meta-analysis. The second part of the talk, which was about timing of proning, again no clear-cut answers. One study by Kimon et al., a small sort of study of a small number of patients, showed that they did show that longer duration of proning did benefit patients and have a more sustained effect on proning, on better PaO to FiO2 ratios. And it looked like those patients who were prone after day 7 seem to have a better outcome. But this was a study which was again a small case series, single center study. And one of the explanations that the authors give was that possibly the inflammation of the lung was better after day 7 and they responded better. However, this was not shown in other studies. A single center prospective non-randomized study by Willinger et al. Did show that there seemed to be faster proning or earlier proning did show to have better response, and also there seemed to be, when they looked at different risk factor predictions, it looked like early proning within about 24 hours of the patient going on ECMO seemed to have a better outcome as compared to all the other indicators that they looked at. The duration of proning, as far as we know today, is still data extrapolated largely from the ProSeva and the other non-ECMO patients, and we know that longer duration, about 16 to 24 hours, seem to have much better sort of sustained response to the proning and better sort of oxygenation and outcomes. A study by Jockman et al. Did show that those patients who had no improvement in the PaO to FiO2 ratio, or who had a PaO to FiO2 ratio less than 150, when proning was continued beyond 24 hours, they seem to have better response. A number of sort of single center, non-randomized trials with ECMO when prone have used different sort of time durations, and most of them have used beyond 15 hours. At least those studies done after 2015 have used duration of about 15 to 24 hours, and there seems to be some benefit in terms of better oxygenation and perhaps a little more sustained improvement in the PaO to FiO2 ratio. Now, having a very high respiratory drive is often detrimental in the scenario of those patients. And of course, we did have talks about awake ECMO and a lot of these things. So one of the fundamental problems in keeping these patients awake in some of them is the increased respiratory drive, and hence balancing the excessive sort of respiratory drive, which can itself cause de-recruitment and self-induced lung injury, versus the negative effects of sedation paralysis, is something that we have to look at based on an individual sort of patient-to-patient basis. The methods to individualize therapy will therefore will also be based on the type of patient, the etiology, and also look at the tangible benefits of going through the exercise of proning on ECMO patients. So that is extremely important to understand, because as I already told you, it's not very easy to prone these patients, but it is not impossible, and studies have shown that it is safe to do that as well. So in all the data that I showed you till now, there is no question of proning being harmful. Definitely it is beneficial in terms of better PaO to FiO2 ratio. And what do we do to individualize the proning for a given patient needs to be done based on what is the optimal peak that the patient will benefit from, because we need to understand that one fundamental problem in these patients who are on ECMO is that the risk of de-recruitment is quite high when we talk about ultra-protective lung ventilation. So in summary, when we have somebody with severe ARDS and on VV ECMO, combining it with proning does have its potential advantages, but we also need to look at the controversial effects and need to decide on the exact timing, which is preferably early. But how long to be prone? Again, long proning of about 16 to 24 hours perhaps, and also look at suppressing the respiratory drive when it is considered detrimental to the patient's clinical state. Thank you.
We are already having given 2 or 3 sessions of proning, right? Dr. Sunil, Yeah. Usually, when we put a patient on Ecmo, before putting on Ecmo, we have given 2 or 3 sessions of proning. So, where do you see a scope of proning after institution of Ecmo in these patients?
Yeah, so there are some case studies which have shown that there is definitely benefit in terms of better recruitment even after putting the patient after the, because if you look at data from ProServe as well, some average proning in some patients has been anywhere between 3 to 4, and many of the studies have shown that sometimes the response is better after the fourth or fifth proning. That's one part. The second part is when you are on ECMO, there is no pressure of maintaining the gas exchange. So the whole focus would be on how to recruit lung better, how to ensure that the advantages of proning in terms of the better or the pathophysiological changes that positive changes that happen. So there is clinical sort of data to say that it does help even in that scenario.
Thank you.
Do you have any personal experience of cloning the patient?
Yes, we not much, I should admit. We have done about 2 patients, out of which one survived, one did not. But I think the first time we did it was out of desperation. So that patient didn't survive. But the second one was not kind of improving after 2 weeks. So we somehow got a CT chest at that point of time, and it did show that there was substantial disease on the posterior part. So actually, when we prone the patient, his compliance improved quite dramatically. And within the next 5 days, he actually came out of ECMO. So, I mean, this is can't be quoted because it's just an individual sort of case person.
So what do you suggest? It's early coding is better or late coding?
So I think it will depend on again. So there is no data to say early is better or late is better, but I think it will depend on how the lung compliance is behaving. So one way of looking at it probably is, I think others can add to this, but I think one way of looking at it would be after going on ECMO, what is the compliance? Is the lung improving? Is the lung getting its rest and getting better? Then probably there is no need to do that. But if we find that the lung is not improving after a period of up to 3 or 5 days, and we find that there is no improvement, then perhaps it may be worth a try.
I would completely agree with that. I think there's limited evidence, absolutely right. But broadly speaking, certainly in my experience, quite a lot of patients will benefit from a late prone when they have that exact position that you're talking about, where they've still got refractory hypoxia, they've got very consolidated bases, and we combine it with physiotherapy in the prone position and also bronchoscopy in the prone position as well, just to try and get those lower lobes rearranged. Any other questions?
Like, is there any data to say which one is better? Awake ECMO or ECMO?
I have not come across that.
About you?
Not on ECMO at
Given a
least.
choice.
I think one of the problems, I'm not sure how awake we can keep the patient when on ECMO in the prone position. That may be a really tall ask, but I'll be happy to be corrected.
No, I agree. So, I was sitting at Boston when I presented this topic day, and someone from the audience asked me the same question. The previous speaker spoke about awake ECMO, getting the patient extubated ASAP. Do you think proning on ECMO would just do the opposite of what it is supposed to? We don't have data. That's the answer to your question. And I think, I agree with what Nick rightly said. You have a select niche of patients who probably will benefit out of it. And we just have to go about how we figure out which patients will benefit out of it. CT scan, electrical impedance tomography, whatever by the bedside. That might be the answer for now.
Yeah.
We need better yardsticks.
What I would say is
Sir,
what I found with when we were talking over COVID, I was so impressed with the way that you've got so many more patients awake and extubated in India than we did in London. And I think there's a cultural element to that. We talked about social elements in the previous session looking at follow-up clinics. So it's a really interesting medical question, but also to go with what the patients will tolerate. And what I found fascinating is how that easily you were able to get people to wake an extra, and there was that expectation that they would be, far more so than we did in London. We have tried phone positioning awake on Ecmo, done that once. It was painful, but actually that particular patient, we offered him the choice of going prone or being reintegrated and getting a tracheostomy. And he said, I don't want a tracheostomy. So he lay there prone, and actually that did facilitate his ability. He remained an ECMO. But that's an F1.
I know. I think that's why it's becoming like diets. Like if some diet works for you and lost a few kilos, you swear by it and say this is the diet everyone should follow. So there are three types of patients. Actually, there's one where you don't even have to incubate them, just encapsulate them awake. And then there's another phenotype where you intubate them, but their compliance and mechanics are such that you can potentially wake them up and extubate, trachea, or whatever. Then there is a third group whose compliance is so bad, if you try to wake them up, you may cause more harm than good. So that's why in future we need to look at trials which enrich of those patient types. So in Canada, actually, they created a platform trial exactly looking at that, where they stratify patient by lung compliance. Once you're on ECMO, you've got very bad lungs, you're then going to proning versus continuing conventional. But if you've got reasonable compliance, you awake versus conventional. So I think you stratify by compliance is the way to go.
Sir, one question, sir. Again, you actually, sir, at any time, do you think that equivalents, all equivalents are associated with significant economics in India? And do you feel that maybe at some point of time, maybe to reduce the duration on ECMO, there will be a prone position on ECMO, may lead to earlier decannulation, earlier improvement of pathology. At some point of time, maybe that can happen, so maybe in the next 3-4 years.
Yeah, so there are a few trials on at the moment to look at the effect of proning on patients with asthma, as Dr. already mentioned. But so I say there are two things. I think we have a lot on the cost perspective. What we have noted in our sort of data, it is not published because we have been reviewing some of our old data. There are patients who refuse ECMO because of the front up cost. Some of them might have survived, but they have spent so many weeks in hospital with 8 or 9 proning. I mean, there are no limits to how much you can prone a person. So I think if you talk about the cost, the first thing we have to also look at is that perhaps if some of them deserve to go on an ECMO, you put them on ECMO early, we will probably end up saving the long-term cost on these patients. And as we already saw in the data, there is good emerging data that long-term outcomes seem to be better in patients who have come out of ECMO rather than who have spent a long time on the ventilator with severe ARDS. So that's just a sort of first answer to your question. When you decide to prone, again, as we spoke, would depend on if you have enough suggestion clinically to say that there is a lot of still a poor compliance on after going on ECMO maybe 3, 4, 5 days. You have stabilized, you have tried your diuresis, not getting better. You can probably think of proning, provided you have enough documentation to say that the lung bases are terribly silted or is really having a bad consolidation. Because if to reach up to that level, probably the only option would be to prone. So on a given patient, yes, it may help. Now, I don't know whether data is going to come in the next 3 years, but I think if you look at a specific individual scenarios as we spoke, it may have some role to reduce the time duration.
Thank you very much, and thank you to all of our speakers. We'll have to leave the questions out. I'm really sorry, we need to get to a tea break. But thank you to our wonderful speakers. We've had an excellent session, and to our panel. And I look forward to joining you again after the tea break.
Thank you, respected speakers and moderators, for such valuable talks.